Well, welcome everybody. I'm Mark Miller, the director of the Children's Environmental Health Center at the Office of Environmental Health Hazard Assessment at California Environmental Protection Agency. Welcome to the second in our virtual symposium series on heat and the impacts of children and pregnancy. The first session was held in April and focused on pediatrics. The session today will focus on pregnancy and review physiology and epidemiology of the health impacts of heat in pregnant people and their offspring. There are two following sessions. The next one will be on June 7th at 11:15 for an hour and a half. And you can see the registration link is there on the slide, but also the QR code in the lower left of the page will take you to the page where eventually all of the videos from these sessions will be posted, as well as registration for the coming sessions. Today's agenda includes a start with pregnancy physiologic considerations, moving to birth outcomes in particular, and then a clinical perspective. Our speakers are wonderful. We're really excited to have them join us, and we hope that you'll find them so. A few key points for audience participation. If you have just an important clarifying question, we will take one or two of those immediately following each presentation. But really, this is designed to be 3 shorter talks followed by a longer discussion panel period at the end, and all the other questions will be incorporated into that part of the session. If you have a question, you can either put your question into the chat box as we go along, or raise your hand during the discussion panel, and we can call on you. When you are called upon, one of the hosts will ask for permission to unmute you. So at this time, I'd like to introduce our first speaker. Let her get her slides up. And that is Anna Bonell, who is a clinician and research fellow at the London School of Hygiene and Tropical Medicine, and has been studying the impacts of heat on pregnancy in the Gambia. Thank you, Anna. Please go ahead.
Thank you, Mark, and thank you, Stephanie, for organising. And it's a great privilege to be here with you today and to join this fantastic panel talking about heat in pregnancy. So my background is as a physician with expertise in anaesthetics and maternal physiology, and I've spent the last 4 years working in the Gambia in West Africa, looking at the impact, exploring the impact of heat on maternal and child health. And today I will be talking about a little bit about the global context of climate change, but mainly focusing on the physiological responses to heat and why pregnancy is considered a vulnerable time, and how we can understand the impact of heat in terms of the mechanisms behind the adverse birth outcomes that we will go on to explore in later talks. So first of all, I feel like it's quite important that we place it, the impacts that we're going to be talking about for the next hour within the more broader context of the climate crisis. And this is because climate change affects so many different aspects of health. And the vulnerable populations that we are talking about, especially in terms of pregnancy, are not only affected by extreme heat, but also are at increased risks of the impacts of other factors that are affected by climate change, such as non-communicable diseases, mental health, food security, and waterborne diseases. So although we will be focused very much on heat, it's important that we hold it in our minds that there's a much broader crisis that needs addressing going forward. And with that in mind, it's also important to recognize the fact that although everywhere in the world is being impacted by climate change and extreme heat events are being felt in every continent, we know that the tropical and subtropical areas are the most impacted by extreme weather events. And so often people who are living in extremely vulnerable areas where it's very difficult for them to adapt to these climate stresses are the ones that are experiencing it and yet have contributed very little to the problem. So to dive into the thermoregulation to start with, so I will just talk broadly about thermoregulation, and then I'll hone in on the differences that occur in pregnancy. So first of all, when you're in a hot environment, we have two main mechanisms for how we can respond to that. Behavioral, which are huge and a multitude of different ways in which we can change, and physiological. I will mainly focus on the physiological side, but I will touch on behavioral towards the end of this talk. So our physiological options to maintain our heat balance, which is very important for us because we are endotherms and need to keep our core temperature very closely regulated. We have two main ways in which we do that. And one is through sweating, and the other is through diversion of blood flow to the skin, which then allows heat loss through the skin. And when we talk about thermoregulation, we have this idea of compensable and uncompensable heat load. And a compensable heat load really refers to when you're in a hot environment, but your physiology can respond to that heat and keep your core temperature within your normal range. And although you have the changes that I've described in terms of sweating and change in your skin blood flow, you won't go on to develop any symptoms or problems with heat illness. But if you are in an uncompensable heat load environment, that means that you have crossed into being in conditions where your physiological mechanisms are no longer able to maintain your core temperature within the range that allows us to function. And then that leads to a whole host of problems, including heat illness, and then eventually it will lead to heat stroke and death. And when I think about these two factors, it's these compensable and uncompensable, there's a few kind of target areas which are important in pregnancy. So in pregnancy, even if you're in a compensable heat environment, we know that you get this big diversion of blood from the internal organs to the skin. And when we talk about internal organs and we're talking about pregnancy, this also includes the placenta. So there's a risk to placental blood flow, even in a compensable heat load. And when we think about the uncompensable heat load, then there's the increased risk of dehydration, activation of your inflammatory markers, changes in your energy supply, all of which can be linked to adverse pregnancy outcomes. So just to bring it back to pregnancy specifically, some of the considerations when it comes to thermoregulation is the normal physiological changes that occur during pregnancy. So we know that by the end of the third trimester, your plasma, the pregnant lady's plasma volume will have increased by up to 50%. Cardiac output will have increased by up to 50%. And although you have an increase in the red blood cells, there is a dilutional anemia that occurs because they don't expand to the same extent as the plasma. There are a whole host of other changes that occur, and I've broadly grouped them into those that increase the risk of heat gain and those that reduce the risk of heat gain. So we know that your surface to volume area ratio is important because that allows you to lose heat more efficiently, and that is altered during pregnancy, and so you reduce the amount of heat loss capabilities from that. We also know that the fetus itself produces heat and is entirely dependent on the maternal circulation to lose that heat, and that you have an increase in your basal metabolic rate, which then again increases your internal heat source, which puts you at increased risk of increasing your core temperature. That is then balanced by the fact that as you are progressively more pregnant, your core temperature actually reduces. You have a reduction in the threshold in which you start to sweat, both of which help to protect you against raising your core temperature to dangerous levels, and other changes such as changes in your specific heat capacity due to the fat content, which also are protective. And so although there is a understanding that pregnant women are likely to be at risk from heat, it's still somewhat uncertain as to whether or not pregnant women can thermoregulate as well as non-pregnant women. And so a recent study that was done by Smallcombe and colleagues did a randomized controlled trial of pregnant and non-pregnant women, where they put them into a heat chamber and exercised them to see how much their core temperature raised. And what they found was there was actually no difference in the core temperature rise in pregnancy versus non-pregnant women, which would imply that potentially pregnant women are no worse at thermoregulation than non-pregnant women. But that said, we know that pregnant women, when exposed to high temperatures, are at risk of illness to themselves, but also at risk for adverse birth outcomes, which you will hear about in much more detail in the later talks. But increased risk of preterm, stillbirth, low birth weight, as well as a whole host of other problems. And so to try and understand why they are at that increased risk, we look at the thermoregulation pathways and think about how they could then impact on the fetus. And so this is a schematic which we created to try to visualize some of these pathways and how they maybe affect the baby. And as I touched on, although we know that maybe pregnant women can thermoregulate, there is the risk that they are in environments where their core temperature goes up, and then that in itself could have an effect on the mother and baby. Dehydration we already spoke about, placental blood flow again because of this diversion of blood to the skin. And then there's a whole host of cytokines and inflammatory proteins which get activated when you're in a heat-stressed environment, which potentially could be detrimental to the fetus. A lot of this remains hypothesized from animal models, but what I will present now is a couple of key findings from the human literature only to show where we are at with our knowledge for the mechanistic pathways to date. So this is our work that we've been doing in the Gambia, actually exploring the change in, so sort of taking that first, sort of one of those mechanisms, looking at whether or not heat stress, so looking at whether or not the maternal core temperature goes up when pregnant women are outside in extreme heat environments and doing their normal tasks. So we focused on Gambian pregnant farmers and followed them for a cohort study to see how they responded to that heat, how that affected their physiology and the physiology of their babies. And what we found was a significant increase in the maternal core temperature and the maternal skin temperature. And when we looked at the heat strain, which is an index that includes temperature and heart rate, we found that with increasing amounts of heat stress, so wet bulb globe temperature is a marker of heat and humidity, that you get increasing heat stress with heat strain with increasing heat stress. So kind of giving some indication that probably there is a role for a rise in maternal temperature acting at a mechanistic level. Now, to look at the placenta, this is much more challenging, especially in a field-based study. So this is a diagram of the fetal circulation, and just to remind you that the fetus is entirely dependent on the placenta and maternal circulation for oxygen and nutrient supply, and that you can measure the umbilical artery Doppler, and which gives you an indication of whether there's any uteroplacental insufficiency. So how well the placenta is able to deliver those nutrients and oxygen to the baby. So we did scans in the field, dynamic scans. So we had a sort of pre-cool scan then whilst they were working in the fields. And what we found was that there was a change in the Doppler of the umbilical artery. And what you can see from the top graph is that as the temperature increases, to around a threshold of 30 degrees Celsius, which is around 86 degrees Fahrenheit in wet bulb globe temperature, you have this threshold effect. And what you would expect to happen is that as the heat increases, you want the resistance index to go down, because that implies that there's more blood flow, and so you're able to deal with that physiological strain. So actually we want to see the resistance index going down. That would be a normal response. But what we see here is that there is a reduction and then potentially a threshold at which the resistance index then starts to increase again. And so maybe this is a point at which people are then at risk of being able to deliver the oxygen and nutrients to the baby. And the bottom graph is just indicating that the black line is women who went on to have a normal delivery, and the red line is those that had an adverse pregnancy outcome, such as preterm birth. And it indicates that potentially there is a difference in the response to the heat stress, although we weren't powered to look at that in this study. And so leading on from this work, this was a very interesting study by Schachner and colleagues, where they have looked into great detail about the placental interface. So this is a randomized controlled trial from Pakistan, where they have taken pregnant women who were part of the trial was all about micronutrient supplementation. And they've then looked at their heat stress exposure. And what they found was that when pregnant women were heat stressed in the first trimester, and they had a definition of heat stress as exposed to more than 20 days of above 39 degrees Celsius or 102 degrees Fahrenheit, they see impacts of placental insufficiency, so a heat-associated growth restriction. So in terms of the babies were smaller, they had shorter lengths, and they had smaller heads. What was interesting in this study is that in the group that were supplemented, they did not see the effect of heat. So potentially being nutritionally deplete may exacerbate the impacts of heat in this setting. They also have done a whole host of epigenetic assessments looking at how well genes are expressed in the placenta. And as you can see, those that are exposed to excessive heat had a differential gene expression. They found 995 genes were expressed differently. And the important genes that they noticed was that there was upregulation of genes associated with placental insufficiency and trophoblastic disease. And this was not only found in terms of the genes, but then when they also looked at protein expression in the placenta, they found differential protein expressions as well. So again, this is giving us an indication that the placenta plays a role in the mechanistic pathways of heat, and yet there's still many, many questions related to this, which we don't know yet. And then finally, just this is unpublished work from our study here, where we're starting to explore the role of inflammation. So we looked at a few different inflammatory markers, and I've just chosen interleukin-6 here to present. And we defined heat strain here as a change in maternal core temperature, as opposed to the environmental conditions. In our case, all the women were exposed to high temperatures. And you can see that there's a significant increase in the interleukin-6 inflammatory marker. And so potentially this could be playing a role. And finally, very quickly, I will just talk about some of the behavioural options that we've explored. This is a qualitative study where we looked at the impacts of climate change on pregnant and recently pregnant subsistence farmers. And what we found was that there was a lot of impacts in terms of how they had the ability to farm what they could farm. We also found that they had significant difficulties when pregnant and working in the heat. However, we found that most of the women were very aware of what options they could take in their setting to try and reduce the heat exposure. However, although they were aware of these things, there were intersecting social economic factors which affected whether or not those adaptation strategies, such as resting more, reducing the amount of farming that was needed to be done, prevented them from taking those heat adaptation options going forward. So that just leaves me to thank everyone who's been involved in the studies, and I'm very happy to take any questions going forward. Thank you very much.
Thank you, Anna. That was both interesting and very clear. And at this moment, we don't have clarifying questions, so we'll leave the discussion to the panel and move on to Rupa, who can put her slides up. I'd like to introduce Rupa Basu, who's the Chief of the Air and Climate Epidemiology section at OEHHA at California EPA. And we're thrilled to have her here to talk about ambient heat exposure and adverse birth outcomes in her studies in California. Thank you, Rupa.
Thank you so much, Mark and Stephanie, for the invitation to speak today. It's really my pleasure to present some of the work that we've done at OEHHA for the last almost 15 years now. So the first thing I want to mention is that it's really important to look at outcomes other than heat-related deaths. And it's because heat-related deaths are very underreported. Some of the reasons that they're underreported is that there is no systematic definition for heat wave in the US. So it really varies by local health department or region. And then we know that by local health department or region, the vulnerable subgroups are very different, and that would impact the heat advisories in these areas. An example of a heat wave definition is 98th percentile of temperature distribution in a specific area for more than 2 days. And it's really important to consider both daytime and nighttime thresholds. In California, we've seen a trend that nighttime temperatures have actually increased during heat waves. And depending on location, the thresholds are very different. So an area such as San Francisco, for example, 80 degrees mean temperature could constitute a heat wave, whereas in Sacramento, that would be a nice day. Another concern is that heat-related deaths or illnesses are only reported during heat wave, which in epidemiology we call a surveillance bias, or when no other cause is suspected. So currently, the Centers for Disease Control estimates approximately about 700 deaths annually in the US, and we know that there are many more than that. And as I said earlier, it's really important to consider health outcomes other than just the classic heat-related deaths and illnesses, dehydration. So far at OEHHA, we have looked at emergency room visits, hospitalizations, mortality. Some of the outcomes we have considered are cardiovascular, respiratory, diabetes, more recently mental health, liver and kidney diseases, infectious diseases, as well as gastrointestinal diseases. And we have found associations with all of these outcomes. And unless we, as epidemiologists or as scientists, consider all of these other health outcomes, we're not really capturing the true impact of heat exposure. In the next few slides, I've highlighted adverse birth outcomes because I will focus on preterm delivery, low birth weight, and stillbirth. Some populations at risk are the elderly. When I first started this research a couple of decades, or actually more than a couple of decades ago, we really thought this was heat would only impact the elderly or mostly impact the elderly, specifically cardiovascular and respiratory mortality. We know now that is not true. That was based on many case reports following heat waves. From epidemiologic studies, we have found that socially isolated populations are also at high risk. Pregnant people, which we will focus the rest of the presentation on. Young children and infants. Outdoor workers, such as farm workers. Taking medications such as beta blockers, which are used for heart disease and antidepressants. And I told you earlier that there's been an association between temperature and cardiovascular disease, as well as mental health. So medication use could modify the associations. Building infrastructure or living on higher floors of apartment buildings are high risk factors, particularly in areas such as Northern California, where we don't have air conditioners as much. Poverty, which is measured in so many different ways. And I'll get into some of those in my next few slides. And young athletes. So the reason I want to bring this up is because currently in heat advisories, we don't have all of these populations listed. And so if people don't know that they're at high risk, they won't be taking precautions. It's really important to include all these vulnerable subgroups, not just the elderly and those with pre-existing diseases. So the next few slides, I'm going to go over some of the work that we've done. This is the first large-scale study of temperature and preterm delivery. We looked at populations in California. And I'm just going to go over some of the results. I don't want to focus so much on the actual effect estimates, but more on the patterns. And so what we see here is that overall, there's about a 9% increase for all pregnant people for preterm delivery. And this is associated with any 10-degree Fahrenheit increase in apparent temperature, which is an association, or which includes temperature and relative humidity. So the first thing that kind of stands out is I didn't show the results for our cardiovascular studies, but those associations were about 2%. And even though we can't directly compare these results, you can see that the associations are much greater for pregnant people, actually much greater than we had even hypothesized. And all pregnant people, regardless of race, are at high risk. However, we do see this disparity here that's pretty pronounced. For example, the white population had about a 6.6% increase, and this overall increase of 9% was largely driven by the other subgroups. So Blacks people compared to white people had over a 2.5 times greater increase. Hispanic, and that's how it's listed in the birth certificate data, also had a higher risk. And Asians, that was a population that we were able to put together, also a pretty diverse population, but still in California, we were able to consider Asian populations as well. We saw a similar pattern for maternal age. You can see it's a very clear dose response, meaning that younger people had higher risk than older people. Again, we see regardless of maternal age, there is increased risk, but it's important to really note that there is this disparity also by age. So in that first study, we relied on the California birth certificate data. It did not have a lot of maternal factors, as you can see. We were able to look at age and race and ethnicity, and that's about it. So I put together a grant with the Kaiser Division of Research, and we were able to look at maternal factors that modify the temperature preterm delivery association. So some of the factors that we looked at were smoking status, alcohol use, pre-existing. We also looked at gestational diabetes and pre-existing or gestational hypertension. And you can see that there's not only effect modification by all of these factors, but it's a pretty pronounced risk. So smoking, for example, or alcohol use have about a 30% increase. Medical conditions such as diabetes, hypertensions. I also didn't list this, but preeclampsia was another one. You can see it's a very, very high risk. Then we moved on to looking at temperature and the risk of stillbirth. The preterm delivery and the stillbirth study, these are both short-term exposures. And what we kind of see off the bat is this whole year for stillbirth was largely driven by the warm season. So during the cold season, You can see that there's really no association or no significant association. And actually, sometimes it's slightly negative, although again, not significant. What I have listed here is the lag time. So lag of 2 just means prior exposure 2 days prior, and so forth. Lag 2-3 is a cumulative, and then we go up to lag 2-6, which is almost the weekly lag. It just starts at 2 days to give time for the stillbirth, and then goes up through 6. And this is, I didn't mention it, but over 20 gestational weeks. And what kind of stands out is that it takes about a week, just like the preterm delivery, to see an association. This is also the best model fit for those of you who are interested in more of the statistical side. But you can see it's, again, about a 10% increase in risk. Looking at race, ethnicity, maternal age, maternal education, and then infant sex, you can see that there is some effect modification. Again, for the race ethnic groups, it seems like white, Hispanic, and Black people actually had greater risk, but I wouldn't put too much emphasis on this. Unlike the preterm delivery, we didn't see some strong patterns. Also, the confidence intervals overlap with each other, means that they are not statistically different from each other. But there is some evidence of dose response for the maternal age. Again, younger mothers had greater risk, and you could see some slightly greater risk for having a high school education or less at the time of giving birth. Also, male infants may be slightly greater risk. And I think this is the last study I'm going to present. We also have an infant mortality study that I'm not presenting here, but another outcome that we looked at was term low birth weight, and this is just 37 to 44 gestational weeks. I didn't mention this earlier, but instead of looking at counties, we considered climate zones for our studies. They were, these climate zones, there's 16 of them total in California, and they were put together by the California Energy Commission based on weather patterns, energy use, and other factors related to climate. So we thought this was a better depiction of exposure. For example, you can see in this box here, this is Los Angeles County. LA County, we all know, is very diverse and also has several microclimates, and this is captured better by climate zones. There's, you can see there's 3 or 4 climate zones just in that county alone. And what we found here is that low birth weight, or term low birth weight, had a long-term impact as opposed to the short-term impact that we saw from preterm delivery or stillbirth. The full gestation actually had the strongest impact, largely driven by this 3rd trimester. From the race ethnic point of view, we don't really see as much of effect modification, but we still see it. And you can see that for the Black people compared to white, Hispanic, or Asian had the greatest risk for term low birth weight. For age group, there's almost the opposite dose response, where now we have older people at greater risk, except for the 40 plus, but that was a pretty large group. Same with 11 to 18 was a pretty large group. But between 19 and 39, you could see that those age groups are pretty, you could see the dose response for that group, those groups. And then also goes kind of hand in hand with the age is that being more educated actually has a greater risk for this outcome. Male infants, slightly greater risk. And again, you can see that being born during the warm season really carried most of that risk. And remember, it was the 3rd trimester. So that 3rd trimester exposure during the warm season contributed to the greatest risk. So from 2007 onward, the California birth certificate data do have some additional factors that we could look at. And that includes WIC status, or Women, Infant, and Children program, cigarette use, body mass index. And we could see here that post 2007, there's about a 10% increase. So it's the same increase overall, but it's really important to look at these subgroups. And the reason we want to look at these subgroups is not only to identify the high-risk populations, but prevent some of these outcomes from recurring. So being a part of the WIC program did not seem to impact the results here. Actually, we think that maybe some of the high-risk population was missed because not everybody qualifies. So it might be the population that just doesn't qualify, but yet could be at high risk here. And then cigarette use, didn't have the best data for that, but you could see it's a slightly greater risk here. And BMI, this was a surprising finding because this is maternal body mass index, and being underweight had a greater risk. I was actually thinking that overweight, because being able to retain some of the heat and increased core body temperature as a result would have had an impact, but being underweight, so it may be due more to diet and nutrition than anything else for that. And move on to the next slide. So it really varies depending on which outcomes we're looking at, but overall, we could say that Blacks, Asians, and Hispanic people had greater risk, younger age for both stillbirth and preterm delivery, having pre-existing or gestational hypertension, diabetes, alcohol use, and smoking. And these were for preterm delivery. So you might remember that first study that I presented back in 2000, that was published back in 2010, was a first large-scale study. Since then, we've had so much research done throughout the country and throughout the world now that it really shows the consistency of the findings. So being able to publish a systematic review with other, these were all OBGYNs, but that really showed that it wasn't just, chance of finding. It was something that is real. We had 68 studies in this review, consisting of over 32 million births, starting from the beginning of 2007 through the middle of 2019. And in this review, we looked at fine particulate matter, ozone, heat, preterm birth, low birth weight, and stillbirth. I think it's also important to take these findings and get them out to other, not just researchers and scientists. For this one, it went out to other physicians. And that was important because we had published these studies, and we don't want the results to just stay within the epidemiologic scientific community. So by getting this information out to physicians who treat pregnant people, they could give it to their patients and then their caretakers. And this is what we're really hoping for. This is how we're going to be able to see a reduction in some of these pregnancy outcomes. I just want to touch upon the reasons for the disparities that we saw. They're really sometimes markers for socioeconomic status, but there are other things going on. First of all, the exposure itself is greater in certain areas. There's greater exposure to heat and air pollution in communities of color in general. This is known as environmental racism or environmental justice. Certain areas are just closer to power plants, fossil fuel combustion areas. There's also less green space in these areas. And because of their increased cement blacktop, there's an urban heat island effect in those areas. And the root of all of these, or most of these issues, is from historical redlining. The health outcomes also, it's important to say that regardless of the exposure, these health outcomes are already, there's already a disparity, particularly by race, ethnicity, and regardless of the outcomes, the exposures, as I just mentioned, have a disparity. So now with both of them combined, Some of the markers of socioeconomic status that I presented could be race, ethnicity, could be maternal age, the WIC program, of course, but there is also a high cost of using air conditioning, and that may or may not be feasible to use during periods of heat exposure because of the cost. Also, relocation may not be feasible if there's a heat wave or a wildfire event. It might not be feasible to leave. There's no place else to go. Might be required to still work in those conditions. There's also literature to suggest that there's less access to healthcare, or that some populations often use the emergency room visits as their primary care. But we're finding out more and more that even with the same access to healthcare, there may be differential treatment, largely based on skin color. So this is something, all of these are addressable and would make a huge impact, not just on pregnancy outcomes, but on adverse health outcomes from heat and air pollution in general. So some of the ways that our research has been used, I just wanted to give an example. In the California's 4th climate change assessment, we contributed to this. This was released back in 2018. We're actually working on, with other state agencies, the 5th climate change assessment. The US EPA released their climate change assessment at the same time, but it's really important to consider California. Not only do we have these microclimates and the diverse populations, but we are dealing with several, I only touched upon heat here, but several climate change impacts, such as temperature, sea level rise, snowpack, heavy precipitation events, which we experienced quite a bit this year, also drought, and then wildfire events like we've never experienced before. Also, some recent bills in California. Another way that our work has been used almost directly is the Omnibus, SB 65, not to be confused with the federal Omnibus. These are bills in California. It was introduced by Nancy Skinner in 2021. And the main goal was to improve maternal and fetal health outcomes, particularly in communities of color. More recently, just this year, we've had AB 2238 and AB 2240 passed in our state. The 2238 considers extreme heat and puts together a statewide extreme heat ranking system. This is important because for prevention, if we know that a heat wave is coming that is a level 1, for example, versus a level 5, or if it's color coded, a red, which means very dangerous, versus a yellow, maybe that is not as dangerous, just to give examples. This is not how we're ranking them, or we might be, but we're not sure yet what this will be. But that will be very important for prevention. Also, naming the heat waves, it's easier to refer back to them. And if there's multiple heat waves in the same year, which we're seeing a lot of now, we could also name them, and that I think is more importance to them. AB 2240 is directly related to perinatal and infant children's health and extreme heat. Thank you so much. And that's the end of my presentation. If you have any questions, feel free to ask them in the discussion, or if you don't get a chance, you can reach out to me. Thank you.
Thank you very much, Rupa. That was an excellent talk. And you can see how these are building on each other to tell a story, Dr. Bonell's and Dr. Basu's presentations. Now we have the honor of introducing Marya Zlatnik, who's a professor of obstetrics and gynecology and a maternal fetal medicine specialist at the University of California, San Francisco. And she'll give us a clinical perspective on heat and pregnancy. Thank you, Marya.
Thank you very much, Mark. It is a real pleasure to be sharing this panel with Drs. Basu and Bonell, whose research work I'm often quoting when I'm speaking to clinicians. I have no financial disclosures, and I'd like to acknowledge the Ramatush Ohlone people as well as my funders. So I'm going to briefly talk about some of the impacts that I see as a clinician of climate change on reproduction. I realize that we've heard quite a bit about maternal impacts from Dr. Bonell's talk and the fetal impacts that Dr. Basu was just talking about. And then I'd like to go into sort of the clinical perspective of what we can do as far as advising pregnant people, and also a little bit about the impacts of healthcare on climate change. So I think historically, this is sort of how a clinician has thought about climate change and its impact on pregnancy, with sort of an international image and thinking about more disasters in kind of a broad sense. And then, several years ago when Zika started impacting pregnancy and causing birth defects, we started to think a little bit more specifically about pregnancy and how it might be impacted by climate change. And as we've heard, there's a large and growing body of literature looking at how climate change and heat specifically might impact pregnancy, causing outcomes like low birth weight, premature birth, potentially birth defects, other adverse pregnancy outcomes. And really sort of more simplistically as a clinician, when I think about pregnancy and the physiology of pregnancy, pregnant women are very metabolically active. They're breathing 40% more than they would be if they weren't pregnant. They're consuming 20% more oxygen. Their heart is pumping 50% higher. And all these changes actually start quite early in pregnancy. And then in addition, the fetus itself is generating heat because the fetus and the placenta are both metabolically active, and that heat can only leave through the outside, through the pregnant person's body. So all these things together are going to make my patients more susceptible to high heat. As we've heard from Dr. Bonell, we can see impacts on the fetus. So in this study of hers, looking at higher temperatures and an increase in the fetal heart rate under a heat stress situation. But also thinking about the pregnant person. So we can also see impacts on maternal outcomes. So when we look at hypertensive disorders in pregnancy, which are a big concern for me because many of my patients will either have pregnancies that are complicated by pre-existing hypertension or high blood pressure, or may develop pregnancy-related hypertension during the course of pregnancy. So both conditions that can lead to maternal health harm or maternal death even, or fetal risks as well. And so in this study, which there are actually several studies looking at different parts of the world, looking at high heat or seasonal variation in temperatures and the outcome of hyperdisorders in pregnancy. And in distinction to some of the work that Dr. Basu just showed us, where the impact of heat waves seem to be greatest later in pregnancy, in this study, pregnancies that were conceived or were in the first trimester during the heat season were at increased risk for developing hypertension in pregnancy at the end of the pregnancy. So the hypertension would have actually potentially happened in the cool season, but the genesis of that increased risk was during the warm season. And so as temperatures are rising, particularly here in California, are we going to be seeing more women with hypertension disorders of pregnancy when they're conceiving during hotter times? So when translating this then to a clinical situation, how do I think about this? Well, finally, I think the medical community really is starting to become aware. So on the left side, we see a New England Journal of Medicine editorial coming from some of our national leaders, really talking about how obstetric providers need to be educated about climate change and how it's impacting pregnancy. If you're interested in more detail, one of our UCSF medical students, Winnie Fan, just published a review article on climate change and pregnancy this month. So now there really is a growing awareness as clinicians of the fact that we need to address the risk associated with climate change and high heat in pregnancy. So our Western states, PACU, recently developed this fact sheet for providers and other people taking care of pregnant people, which includes some very straightforward advice on sort of how to prepare. And so some of this is general advice that would apply for any kind of disaster, whether it's a climate disaster or not, but things like making a family emergency plan, having a go bag ready, knowing where your area hospitals are. For example, in the recent floods near Gilroy, Highway 101 was closed. If you were a pregnant person who needed to get to a hospital and it was on the other side of that blockage, how are you going to get there? And was there another hospital you might know? And then more specifically related to high heat, what is advice that we can give pregnant people? Some of this is fairly common sense advice, but maybe things that people aren't thinking of. So we need pregnant people to just know about the symptoms of dehydration and heat stress, and in particular, the things related to pregnancy, such as cramping or contractions or decreased fetal movements, that these things are warning signs that should prompt seeking medical attention. What about heat forecasts? Again, this is something new, but something that we probably need to, as time goes on, pay more attention to. And then other things, if people can limit outdoor activities to cooler times of the day, this is obviously going to be harder for our patients who have jobs that require them to be outdoors, agricultural workers, etc. But certainly things that people can do to strategize so that they're exposed to less of that heat, whether they can get shade or something else, make sure they've got plenty of water. If a heat wave is expected, again, as Dr. Basu mentioned, a lot of people, at least in some parts of California, don't have access to their own air conditioning. So is there a local cooling center that you can go to, or a mall that would give you a chance to cool off? Are fans helpful? The medical literature about the benefit of fans when it comes to heat waves is a little bit mixed, and there really isn't any good research specifically looking at pregnancy and at what temperature and humidity a fan is helpful versus not. So making sure that people know that something like a lukewarm shower or bath or moving to an air-conditioned place may be a more effective way and safer way to cool off than using a fan. And then to switch gears a little bit, I think one of the other things that clinicians need to be aware of is that healthcare itself is contributing to climate change. So probably about 10% of US greenhouse gas emissions come from healthcare. So in addition to being aware of how we need to advise patients and how we need to think about climate change and heat events as having health harms, we also need to be thinking about the things that we can do as providers to decrease the carbon footprint of healthcare. And additionally, in the healthcare realm, we also need to make sure that we are doing disaster planning for our hospitals. So if there's a heat wave and there's an impact on the electrical grid, if we lose power, how are we going to deal with that as a healthcare institution to make sure that our hospital continues running and that we are able to care for the people who may have a higher need for healthcare because of the climate disaster? There is good news, however, there are things that we think are health protective. So this recent study modeled decarbonization in California. So this included both building electrification or vehicle electrification in California, and how there would be immediate health benefits due to decreased greenhouse gas emissions and decreased air pollution. And we would see those health benefits, particularly in the most disadvantaged census tracts, which, as Dr. Basu had mentioned, more air pollution, et cetera, placing those communities at higher risk. And decarbonizing would decrease those risks. And we can see a similar result specific to pregnancy. So in this study, some researchers at UCSF and UC Berkeley looked at various coal and oil power plants in the state of California, which closed over time. And then in the most immediate area closest to those plants, so again, many times communities of color, they saw a decrease in the risk of preterm birth when those power plants were closed, and presumably the air pollution decreased. So in conclusion, I'd like to emphasize that clinicians really need to be aware of the vulnerabilities of women and pregnant people to climate change. And we as clinicians need to both work on our climate footprint, but also we need to be able to prepare to advise patients and advocate on behalf of them. Thank you very much.
Thank you, Marya. And all three of our speakers, Hannah Bonell, Rupa Basu, and Marya Zlatnik, and they were three excellent talks. And we're now open for questions. You can raise your hand and we'll call on you, or you could put questions in the chat. While we're waiting for those to come, I'd like to ask, what is being done about the disparities in heat outcomes between pregnant people and within high-risk groups of pregnant people, and particularly thinking back also to the discussion about intersecting social and economic factors that impact pregnancy. Any of you, please.
I'll chime in. I think there is more awareness right now about maternal mortality and morbidity than there has been in a long time. I mean, I think the events over the last several years has sort of raised awareness. And so as Dr. Basu mentioned, the omnibus bill at the federal level has a lot of protections built in for pregnant women, and really there's a focus on protecting women of color. And so some of that has to do with racism in healthcare, some of that has to do with encouraging better access to the things that people need to be healthy in pregnancy. But also, I think the things that are coming with the IRA and money going towards improving air quality throughout the United States by moving away from fossil fuels, I think all those things will be protective of women of color and will hopefully address some of these racial disparities. But we also have to work on the clinical level as well. Thank you.
Others?
I was just going to come in for a little bit of a different context from West Africa. I think part of the challenges here, which is, I think, probably the problem that we see with a lot of action on climate health impacts, is that it almost feels so difficult to start that people don't even start, because there's this massive, it feels like there needs to be a massive change in the way everything is done in order to affect the health benefits. So because it affects the sort of most vulnerable and lowest, and sort of like, the people who have the least power and the least agency to change where they're at, you kind of feel like there needs to be this huge sort of structural transformation. And on top of that, we know that we haven't even turned the tap off. Carbon dioxide is being released at, it's still going, it's still being released at sort of increasing amounts. And from this context, when we speak to people about what interventions they would like to see, again, you sort of feel that people are in this situation where they almost can't envisage what those interventions would look like. But there's certainly a very strong drive here to move towards nature-based solutions as a way that people are very committed to the idea that we need to preserve the landscape, preserve the trees as a way to help protect the overall exposure to heat. And I think that's because they see this very clear link between deforestation and extreme heat exposure as a kind of starting point, I think. But I agree that there's a lot that needs to be done in terms of education as well going forward.
Can I just add to that just a few things? I think maternal health and education needs to be addressed. Often it's kind of the last thing to be included. I think now we have some more climate change awareness, just because regardless of where we live, we're already seeing the impacts of climate change. It used to be something that we'd talk about happening in the future. Now that we're seeing it, it's a lot more relevant, and that in itself increases the awareness. But I think where we need more education is with the populations that are at high risk. Even though it might be obvious to us as scientists, I think getting this information out, the public health messaging, is so important. And we're still struggling with some of that. And but I think that that's going to be the key to prevention moving forward.
Yeah, I can't help but note Dr. Bonell's quotes from various of the people that very powerful. And I wonder about, do you have specific ideas? I mean, I think that kind of thing in a public realm is a powerful statement, but can you talk a little bit more specifically about challenges in communicating and with pregnant people, what has worked and what you think we can learn from things that haven't?
Yeah, I think over the years, I've realized that it's so important to be co-developing solutions, and that actually we really need to focus very much on what's the reality on the ground and look at what would be feasible and what would suit that situation. And so having a one kind of fix-it-all solution will not work in this situation at all. I think from the discussions that we've had with the pregnant women here, they are I feel like there's this very strong drive to also protect the natural environments, but they don't have the same agency, so they are unable to enact those changes that they would like to see. So in terms of reducing the amount of logging and things like this that you see, the loss of the big trees that occurs in this region, and then in terms of economic challenges, very much the group that we focused on were the most vulnerable in the population. So these are the people who are living kind of with hand to mouth, and so if they don't go to farm, then they will not have the food to provide for their kids. Which then reduces the chances of them being able to adapt to the challenges that they are facing. But that said, we see from the Gambia anyway, from our other engagement activities, that there is a very strong community-driven desire to see a change and to see action on climate and health. And that's not just from pregnant women, but also from our work with students and youth leaders. And so that kind of gives me hope that although it does almost feel insurmountable at times, that there is a real drive on the ground to see things change.
Either of you others want to chime in on that?
I just have sort of an interesting thought. One of my colleagues in the Philippines, Dr. Ditas Decina, has been part of a project to plant a tree with every new baby born, with the idea that that is, you know, sort of an ongoing project to combat climate change, which obviously in the Philippines is, you know, clearly on a daily basis already present.
And I really like also what Dr. Bonell said about how a specific intervention in one area may not work for another. And, you know, populations are so different, even within local regions in California. So when we're thinking about preventive efforts, we have to think about what's feasible and feasible solutions for each of the locations that we are studying. Otherwise, it doesn't really make sense to talk about public health interventions. For example, something that I hear a lot is just go to a cooling center. Well, if you look at the data, it shows that cooling centers actually haven't been that effective because people often don't even know about them in their community, or they don't have the transportation, or don't feel comfortable, especially in the era of this pandemic. So just thinking about interventions that are feasible and vary by location are so important.
So this may seem a little bit reiterating all points that you've all made, but one question that's come up is, why are pregnant people so important to consider specifically? So that's really the foundation of this Symposia series, is that the idea that we need to make sure that we specifically consider children and pregnancy when we're thinking about the impacts of heat. But we're interested in your take on that. It's all the foundation of your work for the three of you.
Well, I can't think of a more vulnerable population than pregnant people and their fetuses. So by including them as high-risk populations, I feel like it should be more important to consider these exposures, these outcomes, and the disparities. I often feel like pregnant women, children, infants need so much more evidence to show associations and to take action than other populations. So I mentioned that we've been working on these studies for now 15 years. Just in the last couple of years, there's been a lot of improvement in public health awareness for pregnant people specifically. And for other populations, it would not have taken this long to get where we are.
We have a go ahead.
No, I was just going to echo really what Dr. Basu was saying, is that obviously I think, you know, we all feel very passionately that pregnant women and children are very important. And I guess sort of an additional thing is that if you are, you know, a pregnant person is a loss of, you know, worst case scenario, a maternal death, that then has profound impact on the family and community and the children that are left behind. And so kind of when we consider their health, we want to try and keep them as healthy as possible because they're a vital member of the community. And then if you don't protect whilst you're pregnant, then we know that the kind of, you know, the sort of physiology side of things, that you can affect changes that occur in that unborn child, which will then be felt by that unborn child's unborn child. And so we're not just talking about a one generation impact, we're talking about multi-generational impacts going forward. And so I think that's kind of also important to bear in mind.
I would love to see Dr. Basu, maybe with some of the Kaiser data, actually research that concept specifically with heat and pregnancy. You know, there's quite a body of literature looking at a variety of intergenerational impacts, whether it's hypertension in pregnancy and impacts on future generations, or malnutrition and impacts on future generations. And I don't think I've yet seen any studies looking at the impact of a heat wave in one pregnancy and then how that might impact to future generations. And I'm wondering if you could explore that with the Kaiser data.
That would be great to be able to do that. No, I haven't seen studies that have looked at that either. But something that we all didn't really touch upon is the long-term effects of fetuses or infants who are born preterm. We know that some of the effects are long-term neurological, some respiratory and cardiovascular as well, more birth defects, et cetera. So yeah, that's just intergenerational is very important to study.
Yeah, we have a question from Isame Pasillas.
Yes, hi everybody. So my name is Isame. I'm with a nonprofit agency, Comité Cívico del Valle, and we're based out of Imperial County. And so I just want to say thank you for the information. I feel like it's very important to know along the lines of the impact that heat illness has on infants, specifically children. And my question is centered around a I know that Rupa, you mentioned that there was some legislation around like heat wave index, and you mentioned AB 2238 and AB 2240. But my specific question, see, we here in Imperial County deal with high heat, anywhere from 110 to 116, 120 during the summer, and we don't really see a lot of information or like public health information in regards to how to stay safe, how children stay safe. We have, and my question is, the way I want to approach this is, so we have a air quality school flag program that we have implemented throughout the elementary schools here through a partnership that we have with CNRA, through an environmental campaign we have with the Salton Sea Community Outreach and Engagement, as well as another partnership we have with IQ Air. And we work together to help children and mothers and parents understand like air quality impacts on asthmatic children or people with upper respiratory. So the question here is, heat is an issue that we deal with starting now, April up until October, like mid-October. We have like 6 months of like summer high heat. I mean, this weekend we're gonna peak 100 during the 12 to 3 p.m. slot, and we have a lot of questions from like administrators and schools with how they can keep their children or their school safe. So I know that public health awareness is like a reoccurring theme, and how and where would we be able to get access to like resources and education to share with school districts, with schools, so that they can keep children safe, for example, during their like recess or their 45-minute outdoor recess period. Is there anything that you would like to share in regards to that?
So I think you bring up a very good point. We need to be a lot better about getting information out, and school children are another high-risk group, and being specific for that location, because as you said, the temperatures are going to already go into the 100 degrees range. So yeah, some of the interventions, I have seen some fact sheets come out we have one for heat and pregnancy. That's one way to get this information. It's on our website. CDPH also has some heat. I guess they have some fact sheets also, but I was thinking for you need something more specific for school children and guidelines on what temperatures should we say, okay, we're not going out at this moment? Or at what temperatures do we say that we cancel sports? This is something we really need to work on with this clear message. I have seen some county level reports. I have seen some heat health action plans that have been more county specific, but to have a statewide plan that then kind of trickles down to the local health departments is something that we still need to develop.
I'd like to also say that we will be venturing into some of the topics that you've questioned about Isame in the next 2 sessions. So please join us for that. We have a hand up from Sharon, and I know she needs to leave soon, so please join us now.
Hi, thank you. Great talks, everyone. I am a member of the Organization of Teratology Information Specialists, and our service is mother to baby, and we are nationwide. I'm based in Connecticut, but as you might know, you have a mother to baby California as well. I jumped on to listen, even though heat really isn't a big issue really for us in Connecticut, but we have the ability to reach thousands of individuals. And we have fact sheets, we have podcasts, and we have blogs that are utilized immensely and all written in lower reading format and so forth. But so I was wondering if there's a way that we could work together to get that information, this information about heat, onto our website. We have worked directly with the CDC on many things. I'm not sure if this is something that's in their wheelhouse right now or not, but they have gone as far as to recommend individuals reach out to us about Zika, reach out to us about COVID on their websites. So we are a international, but national organization that has the ability to reach out. And I'm wondering if whoever is in charge or whoever is interested, we don't focus on children. We work with our local PACEUs as well, and because we're HRSA funded like they are. And so collaboration is what the CDC, the funders always like us to do. So that's something I'm offering up for anybody who wants to reach out, and then I can put you in touch with the people that would work to make something like that happen.
Thank you, Sharon. I love mother to baby. It's a great resource for clinicians. We use it. We send pregnant people there all the time, and I would certainly be very happy to collaborate. The Western States PACEU climate change fact sheet that Stephanie just shared in the chat and that I mentioned, the body of it was intended to educate clinicians and providers, but the sort of nitty-gritty on practical advice was intended to be patient facing. So that would definitely be something that we could share.
Yeah. Love to do. I mean, if there's something that's already created, fine, then we can, get it approved to be posted onto our site. If there are more steps you want to take, whether one of you wants to give a podcast, one of you wants to write a blog, that's what people like to do mostly, is not necessarily talk to anybody, but read something or listen to something. And we text and chat and email. So it would be great to collaborate. So Mark, I gave you my email. If you would be so kind as to connect me to the others, and that maybe we can work something out.
Very nice.
Thank you.
Yeah, thank you. Any thoughts from the 3 of you? It's nice to have people inviting you to contribute to ongoing efforts.
Yes.
I'll also note that there's a couple different resources, few different resources that have been posted to the chat for people. So.
Yes, and I agree that collaborations that are very important in getting this message out. We have just started at OEHHA to do fact sheets. We also considered starting a blog but we haven't gotten there yet. And as you can see in the chat, I mentioned CDPH does have some interim guidelines for heat in school children, and then PASU also has a pregnancy fact sheet as well. And I feel like this is the area, rather than at least just doing the research, we need to get this research, disseminate this information in a practical format. I like how Sharon mentioned that, you know, people really like to read things. Now it's, you know, everyone's so busy, to attend a presentation is difficult, but if there's just a few lines that are just get the information out really quickly, and in a way, convey the information in a way that is understandable and relevant, so important. So Sharon, yes, I know we would be very happy to work with you.
Great. We'd also have Facebook pages. So, and then we post things. I don't know if you've seen that before, but that's another way to, you know, they're all on their phones, you know, that's a way to reach them.
Other questions from the participant audience? Well, we've answered the questions that we've had. We had as a backup kind of question, which I think still might be a valuable one. We put it aside, but you know, research needs. Are there really some specific research needs that would help you in applying this information? You know, how do we move forward? Do you have thoughts on that?
Well, I certainly do as a clinician, because I think as a clinician, I'm always sort of thinking, right, what is the evidence base for telling somebody something? And as Rupa mentioned, you know, like if I tell somebody to go to a cooling center, but there isn't a cooling center available, or they're uncomfortable going there for some other reason, then my advice is not helpful. And so I think one of the things that we really need are sort of those basic studies that tell us, you know, if you share this information, does that actually help improve outcomes? Or, you know, the specifics of things like, is a fan going to be helpful? Or is there something else sort of that we could be doing that should be, does it actually make a difference in the health outcomes? I think those kinds of research are really important.
Yeah, I couldn't agree more. I think the need for evidence-based interventions is just huge. It's just missing. So yeah, there's a lot that could be done on that. And as we've already seen, you know, the impacts of climate change are here. We're all suffering with it. And so kind of going back to the basic science by itself, it feels too late for that now, really. We need to be also trying to kind of maybe combine it with some of the sort of intervention studies so that we can further our knowledge, but also look at what would be effective in different settings.
Well, that's a great advertisement for session number 3, which is strategies to combat health effects of heat in children and pregnancy. And we'll be trying to look at what evidence base is there for that. So, Rupa, were you going to add another?
Yeah, research needs. I would say that we could benefit from personal monitoring studies for pregnant people specifically. There have been some done in, I remember doing a pilot study a long time ago on the elderly population in senior community centers. There's been some work done on farm workers and on the military, but still I haven't seen this work done in pregnant people specifically. Of course, the mechanisms are completely different. If we can understand exactly what's going on in the body with the core body temperature, and Dr. Bonell did so much work already on kind of the background to the thermoregulatory response, but I think we could get some more information from that. On the flip side, if we want to do more population-based studies, I think doing studies in local communities would be very helpful. So we already know where the high-risk populations are. So to kind of focus in on those populations and offer some interventions and compare what works in certain areas and doesn't work, and then maybe bringing it to other areas and kind of doing the same. The last thing I could say is maybe looking at more recent data, particularly for heat waves. The studies that I showed were all based on background levels of apparent temperature, so temperature that we've already experienced. But we want to know, is this association getting worse, and how much worse is it getting? And then with these interventions, how much better are they getting? So I think those would be important research objectives.
Yeah, very important. This came up in both of our sessions so far, the potential for differential impact with people with underlying medical problems. So both in children with chronic disease impacted by heat, and Rupa, you presented specific examples during pregnancy, and wondering about comments of that, and particularly for Dr. Zlatnik, is there an effort to target in the clinical community the pregnancies that are occurring, in people with underlying medical conditions that might put them at particular risk to heat exposure?
Thank you, Mark. Yeah, I mean, certainly people with pregnancies that are complicated by underlying medical conditions in general are getting more monitoring, are followed more closely, but whether they're getting any advice at all specifically related to heat, that's really hard to say. And it is complicated. I think, we could see some of that in Rupa's data, where some groups that you might think would be higher risk for some things are not, and vice versa. And, whether that relates to whether people have access to medical care, or whether they're getting, specific interventions around stillbirth or preterm birth, et cetera. So it's complicated, but certainly I think clinicians need to be aware that that's something that we can talk about. I was wondering a little bit about the legislation that Rupa mentioned. What are the specific sort of health protections for pregnancy in those laws? Can you speak to that?
So first, I want to comment on what you were saying about the mechanism and not really connecting the symptoms that pregnant people might have to the heat, because some of the symptoms are very similar to what we would see for pregnant people in general, like dehydration, nausea, vomiting. And so that connection is often not made. But with more education in the clinical world, I think we could inform healthcare practitioners. So with the bills themselves, they are still developing, particularly the ones that are just came out in 2023. So yeah, I don't want to comment too much on those, just because I know between all of the state agencies, ours included, there's going to be so much discussion, but to be continued.
Well, thank you. I think we're just about at our time limit. We've had both three wonderful presentations that fit together very nicely, as well as a stimulating discussion period. So I want to thank all three of our eminent speakers for joining us today. It's an honor to have you. And I'd like to point out again that session number 3, Strategies to Combat Health Effects in Heat in Children in Pregnancy, will be on Wednesday, June 7th 11:15 a.m. to 12:45, same time as this Pacific time. So please adjust for those that are coming from elsewhere.
It's actually an hour later than this session, Mark. It's the same time as the prior.
Oh, it says those the first one. Thank you, Stephanie. Yes, and so adjust time to that this is a Pacific time. Registration is open, and you can find that on our website. And I think with you, all of the attendees today also got that in an email yesterday. So please register if you're not haven't already. Thank you, Stephanie. Before we conclude, do you have anything you need to tell people?
Nothing else. I just put the link in the chat for the info for upcoming sessions. So registration for session 3 is there. That's where the videos from the first session should be momentarily. We've been told they're going up today. If you want to be able to catch that if you missed it, and the videos from this one should be there soon as well.
Okay. Thank you all.
Thank you very much. Thank you, Mark, Stephanie.
Yeah. Thank you, Anna.
Thanks so much. Bye.